Welcome everybody to 52 Living Ideas. Tonight is Comprehensivist Wednesdays. This is done in conjunction with the Greater Philadelphia Thinking Society. Tonight's topic, aphasia. Now, this is Neuroscience Wednesdays. Sanjay's typically led our neuroscience discussions. He has a whole series on it. For tonight's structure, we're going to have about 30 minutes of lecture. Then we're going to have a breakout and our Q&A, and then we'll have a breakout, and then we'll have another, we'll come back over our breakout rooms. We'll have another set of slides that Sanjay will present, and then we'll close the meetup out. Does that work for you, Sanjay?
Sure.
Okay. All right. Well, Sanjay, take it away.
All right, thanks. So good evening, everyone. I see some new faces that haven't attended before, but this is a series that we do, and we go into many types of topics around neuroscience, and primarily it's geared toward learning and helping people understand, knowledge and trends in neurosciences. And tonight we're going to talk about a topic that actually came up in recent media. Some of you may have heard of it. It's prompted by a particular political candidate who he held an interview at which he disclosed. Many people already knew that he had a stroke, but he disclosed aspects of it, and we learned from that he had aphasia, which is a condition that arises oftentimes from stroke, and it affects language processing, language skills in people. So that's the main topic discussion for tonight. And so let me start. I usually, what I do is I have slides and I go through a lot of information. So in the beginning, I'll talk about stroke and aphasia in general, and then I'll turn off the slides and we'll have some question and answer to make sure that everyone understands what it is, and then we'll go in more depth into that. So anything initially that anybody has before we start rolling into the slides? You can raise your virtual hand or your physical hand. It doesn't look, or you can say something if you. But it looks like we're fine. So let me start.
Okay.
Joe, I'm not able to share screen. I don't know if.
Oh, forgive me. Hang on. Try now.
Let me try. Okay. Okay, so how's that? That should be.
Looks good.
All right. So let me. So let's first start talking about stroke itself. So stroke is something that people know about. They have a general idea, and one of the things that is under. I'm going to go into, and again, this is not a talk specifically about the medical aspects. We do want to have some type of understanding, because when we're talking about the neurosciences, we want to understand exactly what it is in the brain that's happening in a stroke. And stroke is a specific disease state that affects the brain. It's specific to the brain, and primarily it interferes or interrupts. It's an interruption of the blood flow to one or more regions of the brain. And what that does is that causes a lack of oxygen specifically, and oxygen is one of the key elements that goes into metabolism, goes into energy, and goes into cell survival, cell nutrients, cell metabolism, and survival. Blood is also important for cooling and for transporting other molecules, enzymes, neurotransmitters, many things that are transported between the brain and body, and sometimes within the brain, but that's usually not through the blood. So there are many aspects of blood that are critical for brain function. And so when there's an interruption, especially severe interruption, that causes the problem. And so because the brain is the most active and energy dependent organs that we have, that humans have, interruption in blood flow and interruption in energy especially has a dramatic impact on our brain. So usually what happens, it causes neuronal death. It causes death of neuronal tissue. It causes neurons to die, and also the support system, the glial cells around it, to begin to die. primarily, there are two causes for stroke. Either it can be ischemic, which means basically a blood clot. There's a blood clot that stops blood flowing in vein, or it can be hemorrhagic, which means that there's a rupture to one of the blood vessels, which causes blood to leak into the cranial cavity. But the leakage is actually very damaging also. But the hemorrhage actually, reduces or cuts off blood supply to critical areas, and especially it's in one of the major parts of the circulatory system, it will have very severe effect. So this is it's almost always a medical emergency when it happens. Sometimes it can happen in very, very small blood vessels and for example, even capillaries, and once it happens, it kind of clears itself. And many of those instances, a person won't even be aware that they've had what's known as a minor stroke that they've had. They might notice a little bit temporarily, but usually people don't even notice it. But in most cases, in most strokes where the person or somebody around them notices it, it's oftentimes a medical emergency. And in terms of prevalence, it actually occurs in around 15 million times around the world, in 15 million people around the world, just under a million, about 800,000 people in the US alone every year. And of the people who have strokes, around 30% of the people, they end up having aphasia. And I'm going to go into aphasia in a few minutes, but aphasia is the specific condition we're talking about, and I bring it up only because it's pertinent to this, that stroke, in a large percentage, 30% is a quite large percentage, it leads to some aspect of aphasia. And stroke, it causes irreparable damage to neuronal tissue, and it can also cause death, so damage and death. So, and it really depends on the extent of area. So as I mentioned earlier, neuronal cells, which neurons are the primary acting agents within our brain. They are the cells that actually transmit and receive information. They are the ones that are actually active in, what we call thinking and emotion and behavior. And then there are other types of cells, glial cells, and there are many types of glial cells that support neurons and the structure within the brain. And they also provide a framework. They also provide physical structure to the brain, many things. But basically, strokes can cause damage to both neurons and glial cells. And the most important aspect of this is not simply that neurons die, but the critical element of neurons is the interconnection that neurons have with each other. That's the most important part of neurons, because that's actually what creates behavior. We've talked about many of these things in our past talks, but the connections are the most important part of our brain, and stroke directly impacts the neurons and therefore the connections between the neurons. So therefore the signal that flows between neurons can't occur anymore if the neurons die, and the connections therefore get lost. So it's a very, very critical aspect of this disease. Strokes are also very time sensitive. And if the person gets to a hospital, to a significant medical care within about an hour, then they have good prognosis for treatment and recovery. But if it's longer than an hour, it gets progressively, and it's non-linearly. So for example, the difference between 2 hours and 3 hours is not the same difference between 0 hours and 1 hour. The second and third hour are much, much more dangerous because a lot more damage has happened by then than happens in the first hour. So it's a very, getting a medical care within the first hour is very important in this. Causes and impairments of function. So these three bullets I've laid out basically are laying out that there's interruption of blood supply that causes irreparable damage, which causes impairment in function and possibly even death if there's enough damage to the brain, or if there's critical parts of the brain, for example, the brainstem, parts of the brainstem that are damaged or destroyed, then death can occur. So the impact affects, so in general, we're talking about stroke right now. So stroke can affect many, many areas of the brain. And usually stroke affects specific regions, although the effect on a region can be quite large. It can be, let's say, a quarter of a brain, in some cases. Typically it's small, but it's still devastating to the person because depending on the region affected, it can cause difficulty. So people are mostly aware of stroke affecting our movement, our muscle control, and sensation. These are common areas because they're two large areas that can be affected by that. It can also affect our cognitive aspects of our behavior, memory, perception, and even our core body. Again, the brainstem that I talked about, which is involved in homeostasis and regulating our body and functions. And depending on the brain regions, it can lead to paralysis, for example, with loss of muscle control. It can lead to cognitive loss. It can lead to both or even death. So it is a very serious condition. It often affects only one hemisphere, and again, because usually it only affects a single circulatory organ, and usually if it affects more than one, the person's already got started to get attention for the first one. It can expand, for example, especially if it's ischemic, if there are blood clots. There may be multiple reasons for them. There may be a heart condition that causes many types of blood clots to form, and those blood clots will travel throughout the body. So in that case, a person may have multiple strokes within the brain simultaneously or within a short period of time. So it's complex, but usually, strokes are one time, and it can be where you have a major stroke and then you have some minor strokes after that, a few minutes or hours subsequent to that. Again, it can affect, it is hemispheric depending on where it hit, but in cases it can actually impact both hemispheres and even other areas. For example, the corpus callosum is the connection between the two hemispheres that can also be interrupted. And depending on the hemisphere, the left hemisphere in most people is responsible for our language, most of our language functions, although the right hemisphere also is involved in it, but the left hemisphere has dominance in that activity, and we're going to focus mainly on that. But depending on which hemisphere is affected and which regions of the brain, different areas of behavior can be affected. And recovery, again, we're going in very rough general things around stroke, and then we're going to go into aphasia after that. So for recovery, it is the difficulty and the time it takes is proportional. Now, again, this is not proportional linearly; it's non-linearly proportional to the extent of damage, the areas of damage, how quickly the stroke was managed and stopped. So there's a lot of issues around this also as far as recovery. And so stroke, basically the onset of stroke, cell death begins immediately. And cell death usually involves, in the beginning, it may be thousands or a few million cells. And again, just for those who may not have been here before or may not know, the human brain, the adult human brain has around 86 billion neurons. A child's brain has more, actually. It has close to 100 billion. And we go through a pruning process in our early to mid-childhood that causes us to, by the time we're in our 30s, we start going down to the 86 billion range. But that 86 billion is our entire brain. What most people think of our brain is actually the cortex, and the cortex has many fewer than that. It actually has around 16 billion cells, neurons, so which is basically 20% of the number of neurons that we have. So it's actually not that much of our brains, but a lot of strokes impact the cortex, and if major areas of the cortex is involved in a stroke, there can be major impact to the person. So the cortex is more fragile because of this, because one, it has fewer cells than other areas. For example, the cerebellum, which is part of our brain that handles movement and proprioception and sensing, etc. That has a lot more cells. It has almost 4 times more than the cortex. So that's it's again more delicate, but it's a smaller area. The brainstem can also be damaged in this, and that's much more serious, more dangerous, and that can actually affect organ function because our brainstem is actually responsible for example, our heart rhythm, heart regulation, lung and breathing, many things. So depending on which part of the brainstem is affected, it can have more serious consequences throughout the body. The cerebellum I just mentioned, it affects movement. It can affect many, but the cerebellum damage to the cerebellum would affect many complex aspects of function, not simply movement, because movement actually occurs through both the cortex and the cerebellum. It's actually much more than just one region. And then the cortical lobes themselves, they can be damaged, and that's usually what we think of when we talk about stroke, but it actually can affect any area of the brain. Just again, we're running through this quickly because this is just for people who don't have a good understanding. The brain has a left and a right hemisphere, and this is very generic, and this is not. Again, a lot of people think that this is hardwired. This is not hardwired. It depends on person to person, and each of these functions can vary. You can actually have your musical skills be in your left hemisphere for some people, and your spoken language in the right hemisphere. So it varies from person to person, although there's dominance and there's averages in the human race, in the human species. So on average, this is what we see in people, but it can vary from person to person. Just as we're left-handed and right-handed, each of these functions also have a handedness. People don't realize a lot of our body functions are actually handed, left and right. So for example, most people have an eye that's more dominant than the other eye. They have a leg that's more dominant than the other. And similarly, a lot of these brain functions are more dominant than not, and they actually can be in the opposite hemisphere than what's found what's found commonly. So anyway, we're looking at averages here, and in a specific case, for our argument's sake, it doesn't matter which hemisphere it happens in, but we're going to look at spoken language as being in the left hemisphere because that's predominant in most people. And there are many other functions that are present in the left hemisphere, in either hemisphere. The other things, for example, and also another thing that some people may be aware of is that the hemispheres actually are cross-lateral, meaning that the left hemisphere controls the right half of the body, and vice versa. The right hemisphere controls the left half of the body. So if there is a stroke in the left hemisphere, it will be noticed in the right side of the body, in the person and the people that are around them. If there's a stroke in the left hemisphere, they may have a droopy face on the right side. On the right side of their face may become droopy, or their right hand or their right leg or something else may become non-functional or semi-functional or erratic. Or their speech may become distorted because half of their mouth, literally half of their mouth, is not able to function correctly. Your tongue, the movement of your lips, things like that, may be difficult for that person because half of the control is from that hemisphere. And that's why, one of the early symptoms that most people are aware of is to look for this either droopiness in the face or a one-sided behavior in the person that's indicative of a stroke. So, our olfactory system, auditory, visual systems, these are also tied to specific hemispheres, and they're opposites on the other side. Logical, scientific thought and processes, number skills, reasoning, etc. These are in the left hemisphere. Imagination, art, music, spatial orientation, grammatical skills, poetry, for example, these are in the right hemisphere. But again, these also, it's not that these are exclusively in one hemisphere. There's actually a lot of cross information that flows between the brain. So when you're doing something musical or imaginative, you're actually using both hemispheres. Rarely do you have an activity that's only occurring in one hemisphere. Usually it's both hemispheres. But what this chart showed is the dominant behaviors that are present in the hemispheres. It's not that they're exclusive to one or the other. That's important to understand. And that's actually important when we talk about recovery, because that's a critical element that's used in recovery. So aphasia is what we're going to go into. This is actually a common result in stroke, and it's a loss of ability. That's the first point that's important to understand. Is it's a loss of ability that was previously held by the person. So, for example, aphasia cannot happen in an infant who never learned how to speak or never learned how to read and write, because they need that ability to be developed and you might say grown in the person. We learn that ability. We learn how to speak. We learn how to read and write. So we have to learn that ability at some point. And after we've learned it, if we lose that ability, then that's one of the criteria for aphasia. And aphasia can happen at any age. It doesn't have to be an adult. It does happen to children also. So it's a loss of ability to speak or understand language. And what's important here is that it's not only, most people think of language as verbal. language is not simply verbal language, and it's not simply heard and auditory. It can be, there are many aspects of language. So for example, when we're reading and we're writing, that's also language, but also sign language. People who are deaf, they actually use the temporal and the very much what happens in a deaf person's brain is the areas that are not used for auditory processing get repurposed. The brain actually encodes and repurposes those areas to help them understand sign language. And it's not the same, but they're comparable activity that happens in similar areas in a deaf person. And similarly, in a blind person, their occipital lobe, the rear of the brain, which is responsible for vision, that gets reused, repurposed if they're blind for things that their hearing may become extrasensory, super sensory, and their occipital, the back regions of the brain, may become recruited for helping them understand. So there are actually people who have learned to use echolocation if they're blind. That's a very difficult skill, but there have been people who have learned that. So what I'm trying to emphasize is that language is not simply spoken or auditory. Language is also visual, and oftentimes it's a combination. And language also comprises a third element, which is the comprehension of language. So irrespective of how you're getting information into your brain, whether it's auditory, whether it's visual, for Helen Keller, for example, those of you who know, she would her therapist, her guide and mentor, would actually touch her hand and she would sign into her hand. So it was tactile for her. She couldn't see, she couldn't hear, but she could feel through her skin. So it was tactile. So no matter how the information gets inside of your brain, that information that has to be processed, it has to be comprehended. So that comprehension can be disrupted also. And then the last aspect is generation. So when you're creating ideas or communication that you want to speak to another person, to the outside world, whether you want to use your voice, or whether you want to use your hand to use sign language, or whether you're using a pencil or pen or a keyboard to type on, it doesn't matter the method that you're using to transmit that information through space. Okay, whether you're using light and photons, for example, in the form of writing on paper, or whether you're using sound in the form of information that flows through space, it doesn't matter. That information has to be generated inside your brain. And there are aspects of generating communicative ideas and information that can be disrupted in aphasia also. And the opposite aspect is the comprehension. So when you hear sound that's spoken by another person, that sound gets decoded into a set of frequencies. Those frequencies get encoded into more complex types of phonemes and structures, and then those structures, transfer through the temporal and even the parts of the temporal occipital lobe and the frontal lobe. It pervades through many areas, and then your brain tries to interpret and tries to understand what those sounds mean, or the squiggles on a piece of paper, the letters, what those squiggles mean. Your brain is trying to interpret what they mean into language. And that's the key aspect that gets disrupted, is any type of processing of language, whether it's spoken, non-spoken, whether it's verbal, visual, it doesn't matter. Any of these elements of language, and sometimes it can be multiple of these elements, they get disrupted. And this has to happen due to either an injury or a disease. So this is the third part of aphasia that by definition is there. And most often the injury happens through a stroke. Sometimes it can happen through an infection, and actually it can happen through other methods. There are cases where people with dementia is where there's a neurological decline, and that can impact Broca's area or Wernicke's area. And that will cause damage, that will cause disruption of signal flow, information flow in the brain, and therefore it can lead to aphasia, early aphasia, or even more serious aphasia in the later stages. So there are many ways that aphasia can happen, but basically it has to be a loss of ability to speak or understand language due to injury or disease. And that ability, you have to have had it before. So a person who never had the ability to speak really can't lose that ability. So that's something that's important to understand. And just some examples of aphasia. So auditory comprehension. So in the Senate candidate that we know of, this person seems to have had primarily loss in auditory processing. So basically, when they hear someone say something, the processing of those sounds into phonemes and into language is what has gotten disrupted. And again, these examples that I've listed here, at the end, the last two bullets actually, let me skip to the last two bullets and explain that each of the above functions can be compound, meaning a specific person, depending on the type of stroke they had and the regions that were affected. One or more of these top level bullets, the top 7 bullets, can be, top 6 bullets, sorry, can be impacted. One or more of them can be impacted. And each of these areas may have a span or a range from either no impact to partial impact to full impairment. And so depending on these 6, and there are actually more than, these are just 6 examples that are named, and they cross, and they're actually impact between them. But for any particular person who has aphasia, there can be multiple types of impairment in these areas. And also the impairment may affect not only one region of the brain, or a few regions, or it can affect most or all language regions of the brain. So depending again on the type of stroke that they had or the condition that led to their aphasia, it doesn't have to be stroke again, as we just saw in the previous slide. Whatever caused it, it can impair larger regions of the brain, which would cause again more of these disruptions. And lastly, a diagnosis of aphasia. This is a very important point that I want to make, is that when somebody is diagnosed with aphasia, what's critical to understand is that the diagnosis means that there is no loss in their thinking ability. So the prefrontal area of the brain or other areas of other types of processing that the person does, there has been no loss due to damage to the regions that are affected by aphasia. That person can have comorbid conditions that, for example, the stroke could have affected other regions of the brain. So in that case, they may have loss of thinking ability, but that's not due to the aphasia. The aphasia is one aspect of their stroke, and the stroke may have damaged other areas which caused other losses. For example, a person may have aphasia as well as loss of motor function. They may lose the ability to control, let's say, their right hand. So not only can they not, they may have disability understanding auditory speech. They may also have lost the ability to write with the right hand. And that can be, a case. But in each case, these are separate indications, and they don't mean that the person's thinking has been affected. But separately, again, in a different person, it is possible that their thinking abilities might have been affected again by loss of other areas of the brain. And compound strokes, more complicated strokes, can lead to aphasia and lead to loss of other functions. So it's a very, very difficult thing to really talk about. We're just going to quickly go through just some very basic things about aphasia treatment. So speech therapy is a dominant mode of therapy that's given today. Most people receive this. There are some pharmacologic, but they're very not used often because they're used mostly in the initial stages to try to minimize damage. But long term, we don't have anything that has a good that supports regeneration right now. There are therapies that also are computer-based, and there are actually new therapies that are developing that are being done. I'm going to mention that. And then also family involvement is crucial in therapy. Family involvement, your social, your environmental environment is very important in treatment. And these are all the normal aspects of treatment. There are also clinical trials and experimental and emerging treatments that are there. They're non-invasive therapies which involve stimulating the brain from outside. Some of you may have heard of TMS and other therapies. There are also pharmacological, some that are promising, although they've been held in very small trials with very small numbers of people, and they need to be replicated in larger groups. So it's not clear if they actually work or if there may have been some other effect that caused those initial studies to appear the way they did. But it's too early, but there may be pharmacological agents that come out in the next few years. And they're also emerging, not there yet, but there are companies working on this. That there are ideas around implants, which again would be invasive. They would require surgery to assist. And some of these actually involve AI-based systems that tie to this. Also, an aspect of treatment is that, again, I mentioned the environment that the person is in. So for complex conditions which involve more than one damaged area, they may include, for example, if the person is able to continue work in their profession, then that they may need occupational therapy. They may need to change their profession depending on the extent of aphasia. So there are many aspects to this that are involved. Just quickly, just the stages of aphasia. So there's 3 primary stages to aphasia. The acute phase, which begins minutes after the stroke has begun, and it lasts for about a few hours. There's major damage during this time where the brain basically, what happens is the brain, and again, if you've been in my talks in the past, you probably remember that many aspects of our body are self-regulating. Our body does a lot of things to regulate itself. The brain is no different. So when the brain, parts of the brain realize, and it's not simply the brain, it's other parts of our body together realize that something is wrong. There are compensatory activities that happen in the brain, and some of them are driven by, for example, our heart or other organs, but the brain also does much of this, where it compensates, and so the brain effectively goes into overdrive. It starts generating many more neurotransmitters, and then some of these neurotransmitters actually cause cell death. So there's, this is one of the areas of pharmacologic treatment which is trying to help, because in the initial stages there's an immense amount of damage that the brain causes in itself, because it's trying to react to a very unusual situation. It doesn't really know what's happened. It's trying to react. It's not like the person can think about what's happening. This is something that's automatic in the brain, but nonetheless it causes damage. And medical attention is essential during this duration, during the acute phase, to rapidly stop damage and loss of tissue. The next stage goes from usually a few days, around 2 days past the stroke, to a few weeks afterwards. And this is where the primary cause of the stroke has ended. If it was a blood clot or something else, that's been usually treated. And then there are concomitant effects. There are also the brain starts to repair. The brain starts to shift its functioning. The brain, the person in the brain, we've realized that things are not right, and so a lot of processes in the brain start to oscillate in a sense. They try to kind of change their function. A lot of things happen, and one of the things that happens oftentimes is the opposite hemisphere. So, in the typical case, that would be the right hemisphere, begins to actually take over function, and that actually vacillates back and forth for several weeks during the subacute phase. And depending on how that happens and how often that happens, that may be indicative of either positive impact or negative impact. But this can actually help in retraining also. And depending on the therapeutic modality, it actually can be a benefit, and it can actually be imposed on the person. For example, TMS, especially magnetic non-invasive treatment. There have been studies have found that it can actually help if you activate the opposite, the right hemisphere in the typical case. Again, medical and social adjuvant therapies can begin during the subacute. Usually they begin, but they can begin in the subacute phase. The last phase is what's known as chronic, and this usually begins around 12 weeks post onset, and it can last for months and years. This doesn't mean that the person is improving all of this time. They can be improving, but this is just a phase during which the brain is changing, and usually after a certain amount of time, the amount of changes is gradual to almost non-existent. But one of the things that I want to emphasize is that, especially with new therapies that have emerged, some of these have found that even years after the person had their initial onset of aphasia, and after their brain has been in the chronic phase, or even in the latter part of the chronic phase where there's almost no improvement seen by clinicians anymore, even then, some of these new therapies that have been tried with permission by the patient they've shown that that person actually has improvements, again, years afterwards. After all other types of improvement have ceased, these new therapies seem to allow them to regenerate new connections. So let's stop here, and then we'll go into. So let's do some question answer, and then we can go into some more after that.
So folks, this is your opportunity to ask some questions to Sanjay. Go ahead and type exclamation point in the chat or raise your hand in Zoom in order to ask any questions. And this is, we'll be going to the breakout rooms shortly thereafter. Vanessa, followed by Ian.
This question may be too soon, but what about if someone's able to learn a new skill like either mathematics or like sign language with the rewiring? Can they maybe get this ability to communicate better, or maybe even better than it was before, like changing, maybe increasing the vocabulary, even though they can't speak it, they may be able to write it?
Yeah, so I mean, definitely they can improve, although it's rare, because one of the aspects to this is that communication is a pretty important part of our life. And when people have, especially when people lose, or in a drastic manner, when they lose many of the critical parts of their ability to communicate, either to understand or to create language, it's very distressing. And so for people who have lost a lot of function, it may be very, very difficult for them to be motivated and to recoup that function, and therefore recoup and then get better than where they were before. It is theoretically possible. And if that happens, it's usually in people who have had very minor, minimal loss, where, because of the extra time and attention that they have, and the support that they have from people, lives usually get put on hold because you're going through a lot of treatment rehabilitation. So that extra time may actually help them to learn other skills. I'm going to go into some of this more, but there are many aspects to this that are non-intuitive. But for example, one of the things that happen with people who lose at least the primary mode of communication is, as part of this, they develop other modes of communication. And so people who had, and this has been seen, many times, this is understood to be probably indicative of everyone, that people who have aphasia, if they have some type of singing ability, or even if they don't have singing ability, but they are motivated to sing, oftentimes they are able to communicate using singing, in a singing voice. And so that's an example where, and some therapies actually emphasize that, because if they aren't able to improve in other methods, and this is a backup method which can be employed, where they're encouraged to speak, and they're actually, I didn't post, I try to find, for the talk, I try to give videos that help people to understand. And there was a video I came across where there was a gentleman who actually demonstrably used singing in everyday life. And it was interesting, and it worked for him. So that's an example where you can actually develop newer skills and improve those skills as part of this, because that person basically, he was already, from what I understand, he was already a good singer, but his singing improved much more because he was doing it, every time he was trying to speak, he was singing. So his singing naturally improved as part of that.
Thank you, Vanessa. So next up, Ian.
Okay, Sanjay, your excellently detailed explanations for the neuroanatomy behind stroke, as well as some of the accompanying materials, the videos for this talk suggests questions about, shall we say, some categories of stroke and their intimate neuroanatomical associations. For instance, one of the accompanying videos stated that when one says or imagines an action-oriented word like dance, run, etc., that it activates actually some areas of the brain, most areas of the brain, which actually would then be involved in coordinating this activity. So one might ask oneself, if, say, a stroke happened in the motor area as opposed to Wernicke's or Broca's area, but happened in the motor area that impaired this joint action, say the activation of, say dance or run, and the stroke happened in the motor area, impaired the activation where you said the word. Would it actually, shall we say, cause a feedback that would impair then language function thusly? And maybe go into maybe some more detailed questions. For instance, stroke, as you said, affect neurons and glial cells. But they might think, okay, if a stroke, say, preferably damage illegal dendrocytes that produce myelin, for instance, might it induce stroke effects that are similar to Lou Gehrig's disease, as Stephen Hawking and the like suffered, or for that matter, if a stroke preferentially destroyed microglia, which are responsible for immune function and for cleanup of neurotoxins. That might induce some specific deficits and the like, and could go down the line. And conversely, for instance, since astrocytes in particular among the glial cells support neurons and may facilitate some aspects of traffic between neurons, is part of the repair process, for instance, say astrocytes taking over some neurotransmitter functions, or at least running some traffic over them during the process of repair. So just some random questions based upon neuroanatomy throughout there.
Okay. Yeah, so interesting questions. So the first question you're asking is and again, one of the videos, if you didn't see the videos, there was one video where they described, and actually this aspect, the preliminary idea around this, I had actually talked to in last month's talk around how ideas form in our brain and how information. And so when you hear a certain word, for example, dancing, there was some, it was simplified definitely because it's a much more complicated issue, but that's an aspect that is related to Ian's question. So if a person hears the word dancing, in the example that he gave, and again, the hearing part of it would cause activation of many areas of the brain, which would cause them to, assuming that the auditory aspect has not been impaired, that they can still hear correctly and they can process the sounds correctly. Once they understand and interpret the meaning of that word to be dancing, then the example that Ian's giving is that their interpretation of what dancing means has been disrupted. And what he's saying is that when the person tries to interpret, or their brain tries to interpret what the sound made by dancing, the sound of the word dancing, what it means to them, that interpretation is miswired. And because some of these regions are close to what are known as the somatomotor functions of our brain, that maybe the information, this cross-wiring, can go into that area and cause them to, maybe move their muscle or something. So that's not seen. And the main reason is because when stroke happens, stroke doesn't cause new connections to form. Stroke causes connections to be lost. So unless the person already had connections between their language processing and their motor functions, so for example, unless they had already trained themselves to have you might say, a knee-jerk reaction when they hear the word dancing and their body moves. Okay, if they had trained themselves to do that, similar to, we've heard of the Pavlovian response. If they had trained themselves to have such a response where they hear the sound of the word dancing and their body moves, then that's hardwired already. And so that person would have that response. But that response would not be created as a part of aphasia or a part of stroke, because stroke removes function, it removes cells and connections. So it would not be, created. And it would not be where the wiring would send the signals in the wrong direction. I mean, theoretically, it's possible, but it would be so rare that, and it is not seen that way. Typically, what happens is that if a person has loss in language processing centers, then as they go through therapy, the therapeutic process one of the goals of the therapeutic process is to rebuild connections to the brain. And so as they're rebuilding connections, depending on how the therapy is being done, if the therapy is being done with a lot of motion, because sometimes motion isn't involved, because if they can't understand spoken language, then the therapist may use visual sight. They may, move their hands or move the patient's hands literally to get them to understand what's happening, to get them to understand what they're trying to explain, because language processing has been disrupted. So if they're using physical means to communicate with the person, then their body, the physical parts of their brain is being activated. So that will form new connections where the sound causes motor activation. It won't cause it, but it'll lower the threshold at which it will activate. So there may be some cross link between that as part of therapy, but usually that doesn't happen. The person, if they see that when they hear things, their body starts to move, they'll suppress that automatically because we don't want that to happen. So that's usually not the case. As far as what you said with glial cells. The quick answer is that so basically, if I understood your question correctly, what you're saying is that can there be more specific death of certain glial cells? You mentioned certain types of astrocytes, and astrocytes are involved in myelin, which is a sheath around axons, which is very important in signal transduction, signal transmission throughout the brain and throughout the body. It's basically what makes nerves function. So strokes don't necessarily target specific types of glial cells only. Strokes are very general and they target all cells in a certain region of the brain. It's possible that if the stroke is deeper into subcortically, that's where we have white matter, and that's where a lot of our glia are. And the astrocytes, therefore, are also there because they're supporting the glia. They're supporting the nerves, the nerve bundles in our subcortical regions. If the hemorrhage, for example, happens deeper in the brain, more closer to the center, that definitely could disrupt more of the white matter. And then in those cases, you would have a very selective type of stroke. And then the type of effect on the person would be more specific. So yes, it can definitely happen. But typically in most common strokes, they're not very specific. They affect a region and all layers of the brain in that region. So I just want to recognize we do have someone with us who, and if the person doesn't want to acknowledge, that's okay. But we have someone who said that they have some aspect of aphasia. So if that's something you want to bring up, that's fine.
Sure, Andy, you're free to share. We'll go to Judy first, and then we can Andy, if you want to share your experience, that's quite all right. If you don't, that's not a problem. Okay. Or then we'll go to Mike after that. I do have one question I want to ask, but Judy first.
Okay, it's a question of aphasia, not aphasia, of strokes affecting emotions and or instinct. And are there any foretelling symptoms that you're going to get a stroke at some point in your life before you get the stroke? Those were my two questions.
Okay, so let me take the second first. That's a little easier to answer. Whether you have symptoms really depends. So stroke is an aspect of our cardiovascular function because blood flow is driven by our cardiovascular system. So if you're aware that you have aspects of cardiovascular disease, that tends to raise, in some cases, it tends to raise the prevalence of stroke. So that's something you can talk to your physician about, your family doctor. You can talk to and try to understand. And if you have a family history of stroke, stroke also, depending on the type of stroke, whether it's hemorrhagic or ischemic, if you tend to have thinner blood vessels, that obviously would increase your risk, and especially if you have cholesterol risk, because cholesterol is directly tied to the blood vessels, the walls of your blood vessels. So if you have both thin genetically, if your family has either thinner blood vessels or risk of cholesterol or both, that would be more important. You may want to look into that because that could increase risk of stroke. So yeah, there are indicators, but when exactly what moment or what minute or what day a person will have it, there are very little cues. Although what tends to happen is that in some types of strokes, in types of strokes, before a person has a major stroke, it's seen that they have had very minor strokes, one or more a few days prior, or sometimes even the day prior. That has happened. There is evidence of that. But again, some of those minor strokes are very difficult to detect unless you know to look for it. And again, that's a reason why you may want to talk to your physician, because if you have some conditions that may predispose you to it, then you may teach yourself using accurate medical sources. You can teach yourself what subtle signs to look for in yourself. And if you see any of these signs, that may be indicative that you're having a very minor stroke, and then you may reach out to a medical professional to get confirmation, and that may actually avoid a major stroke happening. Because in many people, they've had very, very minor strokes occur, and then hours later or a few days later, they've had a major one, similar to earthquakes, in a sense. And your second question, so whether strokes affect emotions, and I think you use the term instinct. So instinct is a very complicated thing, and it's not simply instincts, they're biological instincts, it's not just cognitive instincts. But anyway, so whether strokes can affect, so the quick answer is strokes can affect pretty much any aspect of our brain. From our a stroke can be as narrow and targeted as only affecting your breathing, because in the brainstem there are very specific areas that control, let's say, your respiratory rate, your respiratory system, and your normal, it may affect only your digestive system. So people who have had very minor strokes, the extent of impairment that they see is that they have digestive problems after that, and nothing else. So stroke can be very limited, or it can be more broad and pervasive. Again, it depends on how many areas and which areas of the brain they impact. So again, I don't want us to go into stroke too much, because the topic really is aphasia tonight. It's not stroke, but if people need to understand an aspect of stroke to understand aphasia, that's something we definitely should cover.
So next up we have Mike, followed by Jason, and then we'll go to Andy.
Well, you sort of told me don't talk about strokes anymore, but
well, I mean, if you want to, but yeah, I don't want that to become the topic. That's not
all right. Well, they talk about dry strokes and wet strokes. Now, in both cases, the body increases clotting, cortisol, and inflammation, and that causes more brain destruction, but prolongs life. And I've heard. Have you, if you don't stop the inflammation issues, is that still considered a worthwhile treatment, to let the body inflame things and then just treat it afterwards, or not? And I have a short follow-up after that.
So, okay, so I mean, Mike mentioned terms that people may not be familiar with. A dry stroke basically is an ischemic stroke. It's a stroke where a blood clot is the primary cause of it, and a wet stroke is where blood basically is wet because blood enters the cranial cavities. You have either an aneurysm, or you have a blood vessel that's ruptured, been damaged somehow. So, Mike, I missed the exact. I'm not sure exactly.
Mike, could you clarify your question?
If you stop, the cure is to stop the inflammation and drain and relieve pressure in other ways. But that has that means you might die more likely. You're more likely to die, but if you live, you'll likely have better memory. I'm interested if you run into anything on the trade-offs in that.
Well, I'm not a physician, so I'm not going to be able to answer that in terms of the type of question you're asking. Okay. In general, so when a person is having a stroke, they will go to the ER, the emergency room, and the ER physicians will try to stabilize the person first, and that can entail many different types of treatments. Each of those have their own risks. And again, it also depends on the type of stroke that they have, whether it's a dry stroke or wet stroke, if you want to use those terms. And I'm not going to explain why, and that's not my forte, but the goal for any medical professional is to, one, keep the patient alive. That's the primary goal. And the second goal is to minimize damage, minimize permanent damage from whatever condition they're having. So, hopefully that is sufficient for you. Sorry, I'm not going to.
All right, that's fine. I guess I'm not I don't know half as much as you do in this area. Just thought things.
Yeah,
Short follow up. The Jill Bolte Taylor story. Comment. She knew she needed to dial 911. She could see the dial. She could see, but she couldn't associate what buttons to press and 911 and to get help. So she started pressing buttons at random. She knew enough to do that until finally she got an operator. So you knew you needed to press 911, but you couldn't put it together to know that you needed to make your fingers press 911. But she did get there because she had her stroke in a hospital. She got coverage within the first 10 minutes. And she wrote her book about it, describes, I say, oh, goody, I'm having a stroke. Now I can figure out some of these things that I just read about. Thank you.
Yeah, that's actually a good example, because what that shows is that her cognitive functions were not impaired. At least in that case, they were not impaired. And typically in aphasia, that's also what happens. Not to say that she had aphasia, but she was able to reason that even though she couldn't figure out what the numbers meant, and she couldn't figure out which numbers, which sequence of numbers she had to dial, she realized that there was a pattern to it. And she randomly tried many patterns. So her thinking ability was intact. So that's important to understand, that our thinking ability is separate from any of the other functions that our brains have.
So one quick question I have is, and actually Andy, you may be able to answer this, is that, this is actually, I'm just learning about this myself. So, how common is aphasia? And then it also, from what I've read briefly, was that it can come on as well by a tumor. And it is, it's not just strokes that can cause aphasia as well. So I was just wondering if you could comment on both those.
Yeah, excellent question. So first, it's estimated that aphasia affects around 1 million people in the U.S.
Okay.
So out of all so that's not per year. That's cumulative. I think the number is around 80,000 new cases every year that arise. So the U.S. has around 800,000 strokes a year. Almost 30% of those end up having chronic aphasia. It's around, right now the number is estimated to be around 1 million cases. The second question you asked is yes, definitely, and I'm going into this a little bit. I didn't go a little in more detail, but I actually have slides later that will show examples of what you just asked. So aphasia arises out of damage to specific parts of the brain, and that damage can occur from any number of ways. It doesn't have to be from a stroke. Stroke is one of the more common ways, but aphasia can happen from infections. So I have an example around that of showing it. Actually, you won't be able to interpret it, but you'll see that the damage is very similar. And actually infections can affect. Infection is very different because strokes are limited based on the blood vessels in the brain, but infections can actually move and migrate in much more complex ways. So there are very different aspects to those types of impairments by infection. There's another example I have where a person actually had a glioblastoma, which is cancer.
Right.
And the glioblastoma actually causes weakening and thinning, and that actually led to them having a stroke. So it's not that cancer itself causes aphasia. The cancer usually causes a disruption or a problem in the circulatory system that can cause aphasia. But there are cases which are more rare, where the cancer, if it's spreading especially, can spread to the areas, we talked about the Broca's area and Verticus area, and there are other areas also involved. But the cancer actually affects, and cancer again is is a proliferation of cells. It's a very rapid growth of cells, and that can affect either neuronal cells or can affect glial cells. And that's cancer, unfortunately, is one of those times where brain tissue can actually grow. Neurons can actually grow rapidly, although it's unfortunate because in cancer is a time when we don't want that to happen, including in the brain. So that's a situation where if you have cancerous tissue in some of those areas that affect aphasia, then yes, it can be directly due to a result of the cancer. But more often than not, cancer leads to a stroke, which can cause aphasia.
Thank you for that. So, Andy, would you mind sharing your experience with aphasia, if you wouldn't
Yeah,
mind?
sure. I think so. I can tell you, I had an ischemic stroke in October 2018, and the only effect for me was aphasia, meaning I didn't have any motor skill problems. My speech is, for most people, would consider to be really good, that I'm even talking to you about it. I know I spent some time in the hospital and watched videos of people who had aphasia on YouTube, and I couldn't speak a lot of words at that time, and I was very afraid, that was the rest of my life. So the fact I'm having coherent explanation or something with you guys is a testament to that recovery is possible. But I know from the therapy I've had and the things, it's not because I did some magical thing. It's just largely just luck, in terms of where specifically it happened. And I pointing behind my ear, I didn't know then that this is where aphasia very commonly occurs, because it's a language and reasoning that was explained in the presentation. So I'm good, but not. The interesting thing on the slide was that things that I could do before are no longer here. So for me, that's about mathematics, not complicated mathematics, but I mean like do a spreadsheet or understand your phone number. If you tell me your phone number, I lose the numbers. I can hear what you're saying, but not always write them down. Things like that. So for many people, this would consider not bad, but it's the point about it's things that were clearly there before, but in that instant, no longer there.
And how long was your rehab process, may I ask?
Well, I think technically it's still going on, but in a technical sense, I found an app on my iPad called oh gosh, now I can't think of the word. I'll have to look it up in 1 second. But I found an app on my iPad, and I found overall that was more helpful than actual speech therapy, because the app was something I could do every day. Kind of like at the time, sometimes I would have to go to sleep for hours during the day just from being tired in my brain. So I could do it, whereas the speech therapy was like 1 hour, like once a week. And like that was, I'm sure, helpful, but not as helpful as the ongoing thing. So it took probably, I would say, a good 2 years to feel so much closer to my normal self.
Sanjay, do you have any?
I'm looking for the name of
Sure,
the.
I would be very interested in that app. Sanjay, do you have any questions for Andy? Or
Yeah, I mean, I'll give him a minute.
yeah, sure.
It's funny because I recommend it to people all the time. Oh, here it is. It's called Constant Therapy, and it's on iPad and so on. It costs like as much. I think it was like $25 a month, which for an app is for most people considered like really expensive. But it was a lot cheaper than 1 hour of speech therapy at like, I don't know, $200 or something. And I've told other people about it, and yeah, so there are some others, but that's the one I found, and I really liked it.
Yeah, so Andy, I thank you for joining, and this is a very important topic, and I think you'll help people understand this. One of the things that I want to have people understand, and actually we'll have a breakout session soon after this, where we'll break into probably 2 or 3 small groups, and people will talk amongst each other about this. What I want people to understand is that aphasia is a condition in society. It's there actually, just in this group, in a small group of about 15 people, we have 1 person. So it's definitely out there in the world. What I want people to look at, and I have a little bit of in the talk later. I don't go much into it, but we'll go in. I want us to go more into it into the breakout. But if you can help people understand, the support system that you had, and how if you find that you need other people to have changed their behavior, for example, the speed at which people speak, is that, I mean, in your case, the aphasia doesn't seem to be that severe, although I don't know, in the beginning I'm sure it was, but you've recovered wonderfully. That's fantastic to see. The question I have, the first question is really, how you spoke in the past before this happened. Do you speak more slowly now? Because it may be that your normal rate of speech was slower, because I noticed it is a little slower, but I don't know if this was your normal speed.
I would previously say that I was, like an extrovert person, that I work in sales. So I was probably a very fast talker. And I can hit my stride if I want to, I guess, not when I want to, but, on a general basis, if I'm feeling good or having a good day. I I never stuttered, for example, before I had the stroke. So any slight stuttering or sometimes exaggerated stuttering is a function of the aphasia. But my speech is probably, if I'm running at it successfully, probably not that different, but when I'm struggling for the word or trying to push it out, my wife says sometimes, like, my eyes are like scrunching because I'm trying, like some magical force will push the word out of my head or my mouth.
Yeah. I mean, and so, I mean, you've told us, but if you hadn't told us, I think few people would know that you have any kind of impairment. Not that it's an impairment now. Now it seems to be, very well managed. But yeah, that's very, very, it's wonderful. And I agree with
I've actually done the cognitive tests that are, I forget what the name of it is, but like a full battery of tests because of my insurance and so forth. Not something that the hospital would do, but like I had to pay for it extra myself to support really that, yes, I can talk to somebody, but I'm missing things that were not missing before. And so that's why I kind of wanted to express those things. Like I can see definitely that I'm super lucky compared to a person with aphasia who cannot speak a whole sentence or can only make gibberish sounds. So like I'm great about that. But but there are cognitive reasoning things that if I do them, they can tell like I'm like, I don't know, half of a normal, function.
Right. Yeah.
Well,
Yeah.
thank you so much for joining.
No,
Sanjay, do you
thanks
have
for
anything?
the chance to say it. The one thing I think for everybody's interesting to talk about I live in Philadelphia, so like I'm aware of Fetterman, but I don't know if everybody knows about Bruce Willis,
Yep.
who's retiring from acting. He has aphasia, but it's one thing that's not been mentioned, which is a degenerative form. It's a very, very rare, right? So I don't know if the presenter knows about that, but it's just gets worse as opposed to have any chance to get better.
Yeah. I mean,
So
there are many aspects.
no Die Hard 13 in
No.
the future
No.
because he cannot do it.
Oh, yeah, that's a very challenging situation. Again, I guess when you don't have hope. I mean, the one thing that it seemed that you were able to heal and get better and speak to us here this evening. So thank you very much for sharing your experience.
Actually, one thing I do want to add to that is that what you did, Andy, is when you found that app and you used the app for many hours each day, I think that was a significant benefit, because if you relied on more traditional therapies, which are, again, they're at most a few times a week, a few hours a week. So out of the however many 7 out of all of the hours that we have in 120 hours in a week, if you can only get therapy for 2 or 3 or at most 5 hours out of those 120, it's a very small fraction. But if you can get therapy using an app or something like that for, let's say,
ironically, I don't know how or why this is a part really about the reasoning that you talked about. Like the person can have reasoning even though they have some other deficits, right? So I could use my iPad and I could say to myself, what is aphasia, and watch videos. And then I said, well, maybe there's an app. So it wasn't recommended to me by the hospital. It was recommended to me by my reasoning. And considering at the time, I looked in my hospital room, there was a clock on the wall, but at the time I didn't know what it was. And I didn't even know what it did. And yet I also knew how to research on my iPad. So it's like a weird miracle.
That's great. Yeah, thank you.
Thank you. So do you want to go into breakout rooms? Do you have a question for us, Sanjay? Or do you want to go right into the presentation? I mean, we went a little longer with the Q&A, so
exactly.
we might...
I was going to say the same thing, that we had a longer Q&A, which is good, which is actually very good. Ian also has a question, but I think we can skip the breakout room.
Okay, I agree with you. So that's probably best. So Ian, ask your question, then we'll get started with the second half of the presentation.
Okay, a couple of questions. First, a brief one that was inspired by Andy's testimony. I mentioned the rare neurodegenerative aphasia. The question then would be, does significant head trauma sometimes induce aphasia? For instance, the neurological damage suffered by boxers like late Muhammad Ali. Is aphasia sometimes among the damage? And next is a very probably geeky, very esoteric question that's inspired by linguistics. That is, different languages have different structures, which are presumably reflected at some level in terms of different neuroanatomical wiring. Therefore, would strokes possibly affect, distort language production differently? For instance, like would there be differences in terms of how it might affect an analytic word order language like English or Mandarin, as opposed to a agglutinative language like like the Dravidian language of South India, or for that matter, I recall hearing claims that tonal language, a la Mandarin, Cantonese, and the various Chinese languages, have greater bilateral hemispheric input than relatively non-tonal languages like English. Therefore, once again, given this possible neuroanatomical difference, would a stroke affect the aspects of, say, Mandarin or Cantonese comprehension or production differently from, say, English or Arabic or whatever? So.
Okay, so you've loaded up on the questions there. So let me try to do some justice. Thank you. In terms of the other types of, you mentioned head trauma and other types of conditions that whether they can cause aphasia. Aphasia can happen from any type of damage that ultimately damages neurons, especially damages the connections between neurons. It can be anything. In theory, a boxer or a football player who has sufficient concussions, contusions may suffer damage. And if those damages happen to be in specific areas, then yeah, aphasia or aspects of aphasia may arise. And again, it depending on the region of the brain, it could be other disorders also that they have. So definitely, actually, epilepsy is an area is a disorder which also comes into play, because people with epilepsy is a broad category of disease also, but epilepsy can originate in certain areas. And a lot of the treatment is actually to remove certain regions of the brain. So if they have to remove parts of the brain or sever some of the connections within the brain, then yes, aspects of aphasia can arise. So with the brain, so many things are connected. So there can be impact from many types of damage and harm to the brain. When you talked about language, so something that raised in me is that language. There are many types of languages, and different languages use multiple parts of our brain. So, for example, a lot of the pictogram-based languages, the Far Eastern languages, Chinese, Japanese, Korean, they are require more of the visual processing when you're reading and writing, and more dexterous hand manipulation than European languages, and Indian languages are somewhere in the middle. So depending on the types of languages that you're dealing with, aphasia can affect certain languages more than others. Yeah, that's true. Or it can have more detrimental effects on languages. Now, there's another aspect to this that people may not realize, and I want to raise, is that people who are multilingual, you may not realize this, that if you're multilingual, chances are that you have more than one Broca's area. This has been found, is that the Broca area is there's a general area, but there are also the lobes, the edges of it, also vary based on the language that you're learning. So if you learn more than one language, especially if you learn 2 or 3 languages, you probably have a very complex Broca's area. And so the stroke, or so the damage that causes aphasia, may primarily affect one of those areas, which would impact one of your languages and leave the other language or other languages less affected. So that's an aspect that's been seen. So if a person has learned, let's say, Japanese and English, then their aphasia may actually impact the Japanese more and have less of an impact on English. So that's another example. The third part you asked about, I don't want to go too much into, but that gets more into the paper that I linked in. Ian, you have a strong scientific background, so I recommend you look into that paper. So one of the things you asked about, I'm going to go into. There are intrinsic and extrinsic factors around recovery of stroke-based aphasia, and that paper is specific to stroke-based aphasia. And so depending on the exact nature of the condition that the patient had, of their prior state, and the specifics of their stroke and the damage that happened in the regions that were affected, and also the extrinsic factors, the social factors, the treatment that they're offered, all of these things, those that affect what you're asked about. So I would highly recommend, if you're interested, to look into that paper. It's a pretty good paper and an easy read. Thank you. So if we have nothing else, we can go into the second half of the talk, where we'll quickly wrap up. I understand it's 10:30 now, so yeah, I don't want to go too long into this. Right. So is there anything else, Joe? Shall I start?
No, I think you should go ahead and start. And again, thank you, Andy, for sharing your
Yeah.
experience. I really added to the meetup.
Thank you. Yeah. All right. So let me go back to my slide. I just need to start it. Okay. So you should. I don't know why it did that. Oh, you know what? I had the wrong. Sorry.
No worries.
Okay. So it should be active, right? You should be seeing it.
Yep.
So what we'll do is we'll go into some examples of aphasia. And earlier I talked about so this is a very simple example, and this is where in the last talk that we did, I talked about, and that was about how information is processed and held, and the complex nature of information in our brain. And we had a simple example where a person had a dog named Loki, and they basically heard the word dog or they heard the word Loki, and depending on it, there are several types of processing that happen in the brain. And this is a simplified aspect of that specific to aphasia. So if the person hears the word dog mentioned, okay, there are many, many words, and again, these green dots refer to different aspects of the idea of dog that may light up in a person's brain. Okay, and so, for example, this in the top center part of the brain, this is near the somatosensory area and also the spatial area. So this may be a reference to the sound as well as the physical nature of where the dog is. For example, in your house, okay, because somatosensory, because sound has to do with somatosensory. This central lower area also is in the auditory area. So this may encode the actual sound of a dog's voice or that person's own dog's voice. This area toward the back of the brain, which is on the right of the slide, is in the visual cortex. So this may refer to the sight of the dog, visual presentation of the dog, what they look like, or in general what a dog looks like, not necessarily their own dog, but the idea of a dog in that person's mind. And this is the larger region because there would be more information coded here because there's so many types of dogs in the world, so many different versions of dogs, small and large, and colors and hair textures and patterns, etc. So this is a larger region. So this is a very simple representation of how the concept of dog may be encoded in a specific person's mind. And when they hear the sound of the word dog spoken, or you can take this to be the example of their specific dog, their dog's name is Loki. So all of these regions may activate when they hear this. And again, this is a specific type of aphasia where they don't have difficulty hearing and they don't have difficulty processing and understanding what dog means. But they may have difficulty in understanding, going the next step to understanding what they're hearing. They're not just hearing the word dog, but what is it in reference to the sentence that was spoken. They may have a difference in understanding what do I do with that sound, the meaning of dog, or even of connecting the word to dog. So for example, in this case, the word dog, they heard and they're starting to process, and all of these other words on the right side come to mind. Basically, they pop up in their mind because they're aware of an Akita being a dog, a collie, a hound, a husky, but all of these being dogs. But they're also afraid of dogs having somewhat reddish hair and yellowish hair. But they're aware that dogs don't have orange hair and green. So these lower ones would be negative activations. One thing that we talked about last week that some people may not realize is that the brain doesn't just encode positive activation, it also encodes negative activation. So for example, a dog is not orange. A dog is not a tool. A dog is not a vehicle. Okay, so these are also activations of the brain that would happen. But these would be negative activations. They would be suppressing signal. Whereas the ones, and so this is an example where there may be lots of activations and deactivations in the person's brain based on what thought comes to mind. And that thought in this case came from outside, came from speech that they heard from someone else say it. So the difficulty this person may have may be that they're not able to connect the dots literally, and they're not able to figure out which of these words actually they heard. Their brain heard sounds, okay? And those sounds have to be processed. And after sufficient processing, the person actually realizes that what they heard is the idea of dog. But that realization happens toward the end of that process, okay? And the example that I'm giving here is that last phase of processing in the person with aphasia may have been disrupted, so they don't realize that the sound they heard actually means dog. They're trying to figure out what that sound means. And in their mind, all of these around 12 or 15 thoughts pop in. So they're trying to figure out which of these sounds did I just hear? I heard a word. They recognize that they heard a word, but they don't understand the meaning of that word. They don't understand whether they heard the word for husky, or whether they heard the name of their own dog, Loki, or, strangely, they're going to, and this is what may make it more confusing for them, because they heard, they in their mind, the word for vehicle is activated. And that doesn't make any sense to them, because all of these other sounds, all of these other thoughts that they have are dog related, but a vehicle is not dog related. So to them, it would be very strange. They would have these feelings that I heard something about a dog, but I also heard something about a vehicle, and they can't connect those. So it would be very difficult for them to understand what it is that they, to understand and interpret a specific single word that they heard. So this is one of the characteristics in aphasia. There are many characteristics. It could be that the initial processing breaks down, and that's a situation where the person cannot even understand what they're hearing, or if they're reading it, they can't even understand what the letters mean. They might understand the individual letters, but the letters put together, they can't understand into a word. So there are many aspects to aphasia that can occur across the board, and in a specific person, it may manifest in specific ways. So in this case, the person would not be able to come away with a specific word that they are sure they heard. Like when you hear the word dog, when you hear the sound of somebody enunciating the word dog, immediately in your mind, the idea that goes is dog. Okay, but in a person with aphasia, that may not happen. This is what may happen, is that they may have all of these activations of these thoughts, and they're confused as to which one of these it really is. And through experience, and this is where the therapy comes in, is that through experience, they may realize that in their brain, they have to ignore that most of the time when they have this type of pattern activation, it's probably around either their own dog or a generic dog or the word dog or something to do with dogs. So they might be able to narrow it down to, they heard something about a dog, and they start to learn to ignore all of these other words down at the bottom, these other activations that are happening in their brain when they hear the word dog. So that's an aspect of training and relearning. And if that happens enough times, if they're retrained around the word dog enough times, that this would probably be several hundred to thousands of times that would have to happen with this one word, eventually they would be able to recognize. And in a sense, just as you're learning a new language, when you learn a new language, you have to associate the sound in that language of a word with the meaning and the concept of that in that language. And that's what this person would have to relearn, is that the sound made by somebody, enunciating dog, right, with a g sound at the end and a d sound at the beginning, that sound, those phonemes together, they have to reassociate and relearn that even though they already know English, they want to relearn English in a sense. That's the difficulty in aphasia, especially people who have severe aphasia. Another aspect, the most simple example that I can give, and I have this on a slide, is that what may happen is that a person who has aphasia, they to understand what happens in aphasia, I'm going to go to the next slide just a minute, but what happens in aphasia is that they basically are relearning skills similar to relearning a new language. Okay? To treat the aphasia, the condition of aphasia, they're basically going through very similar processes, and it's almost as if they have to relearn the language that they already knew. And again, this can happen for a speaker of French or German or any language for that matter. It doesn't have to be English speaker. Whatever language is your native language. When aphasia happens, that language skill gets disrupted. And you have to basically relearn the parts of that language that you lost, whether it's hearing or whether it's written or whether it's interpretation and grammar. You have to relearn those aspects. That's the reason why it can be difficult. It can be done, but it does take time. So this next slide is where, and this is more consistent with the language cloud model that I presented last month, is that when they hear the word dog, this is what basically pops in their head. They have a strong notion of animal. Okay? And what the person is trying to do is they're trying to figure out what sound or what word did they hear. They don't know what word they heard. All that they realize is that their brain, if they're aware of this language cloud, this word cloud, where they have a very strong sense of the word of the concept of animal, and they have a little stronger sense of the concept of responsibility. They have a strong sense of the concept of Loki, which happens to be the name of this person's dog, and they have a negative connotation with food, and they might even have a very small, you see in black all these other smaller words. So this is the frame of their mind immediately after they hear the sound, which in their language enunciates the sound of dog, the sound of the word dog. This is what their brain has to decode and figure. This is the state of their brain. And using the state, they have to figure out, what does that sound mean? So over time, they can relearn, they can reteach themselves that sound associates with this brain state, and therefore it associates with probably dog. So anyway, that's one example. Another example, this is the more, actually, let's skip this. This is a little more complicated. So I just have some very quick slides here, and then we'll end after this. I don't want to go too far, but these are some actual examples of MRI images of people who have aphasia. And this is aphasia in the rear temporal area of the left hemisphere. And these two slides are showing different aspects of their different depths in a brain scan of this person. And the white region here on what's the right side, which basically is MRIs are reversed. So this is the left hemisphere. So the white region is the coding in this image shows damage. In a lot of MRIs, it's shown, it's depicted in dark, in black, but in this case, it's depicted as white, as to highlight it. So this large region basically has cells that have effectively died, and they have very few cells. There may be some cells that are still there, but they're so few, and the connections that they have with all of the other cells in the outer regions are so few that those cells really don't function much. They don't provide much benefit to the person. And so this region is effectively non-functional to them. And this region is strongly in the Wernicke's area. So that characteristic of loss would be in this person. Another slide is, and this is a slide where this is actually the example where I cited where a person has a glioblastoma, which is a type of cancer. And what happened in this case, this is actually from a paper that I reviewed for this. And the person actually, it was a woman in her 50s, and she actually had this type of cancer, and that cancer eventually caused her to have a stroke. And the stroke, because she had cancer and the cancer was in multiple regions of her brain, the stroke affected primarily the left side of her brain. So in this case, there's damage both in the right and left side, and then there's stroke, which also causes damage to the left side. So in this case, we have multiple types of damage in this person. So this is what's known as a crossed aphasia. Aphasia is in both regions, left and right hemispheres. And these red and green clusters are basically highlighting the cancerous area as well as the area that was damaged from the stroke. And in this case, the images are shown in what are normal to most of us, the left hemisphere on the left side. So this is pointing to the Broca's area which was damaged in her. So anyway, this was another type. And this is the third example. This is aphasia due to infection. And this is a little more complicated to see because there are many slices of these MRI images. You can look at individual slices of the brain from many different angles. This shows many angles. So in general, this is the common type of image from the top that we're used to seeing. And this is a region of, this is basically toward the front part of the Wernicke's area. And this is where you see it from the rear of the brain. And this is again a different slice to the top. So this again was from, in this case, it was actually, I believe, it was a, anyway, the specific type of infection doesn't matter, but it was infection that they had. And that infection led to damage in this area and other areas. But in this slide, you see that there's damage to multiple other regions, but primarily limited to one hemisphere. And so this person ended up getting aphasia from the infection. So those are three different areas. And just in closing, I want to wrap up, but then we can have some closing thoughts at the end and other questions if people still have. So just at the end, the neuroplasticity around aphasia, and Andy is in our talk, and he was able to provide firsthand evidence of the nature of our brain, the ability to really recover. And as he said, this is really important because he said that at the initial stages of his stroke, he had lost a lot of function. He really could not communicate. He had even difficulty thinking in certain types of processing. But over time, he was able to retrain his brain, and he gained back pretty much all of the functions that he had originally. So neuroplasticity is a real thing. It can happen, it does happen more often than not. And the extent of retraining and regrowth and recovery depends on the amount of initial loss. So there are many aspects here that come to play. So neuroplasticity basically is, what it means is it's a retraining of the brain. And what that means is that you're regrowing connections between regions of the brain, between neurons, but more importantly, larger regions of the brain and specific regions of the brain. So that retraining is effort-based. It requires effort on the patient's behalf. It requires effort also by a large team of professionals, especially the beginning. But as you get into the later stages of recovery, you may only have certain types of therapies that you go to, 1 or 2 types, and that may be more limited to the latter stages. But many people are involved in recovery, and it is a lot of effort, time, and effort spent to retrain the brain. It may be compounded by other types of damage that are, again, concomitant with aphasia. There may be other. So if a person has difficulty with motor functions, for example, they cannot move their lips, okay, their mouth, then, and aphasia affects language, so their ability to speak would be affected not only with the aphasic aspects of loss, but also with the motor function aspects of the ability to speak, move their tongue and move their lips and move their mouth. May also impact their ability to communicate. So that would be much more difficult. But again, through retraining and recovery, they may regain some function, because just as we see that the cognitive aspects of retraining work, the motor aspects of retraining also work. There are many, many cases where a person can actually regain motor skills, the ability to move their limbs or their mouth or their facial features with sufficient support and retraining. Again, this is also requires a lot of support from the family and environment, and work if they continue to work. And one of the aspects that's important is that the people around them need to change how they behave. So in Andy's case, it's he is able to communicate very well, and it seems that he can also understand other people very well. So it may not be as relevant, but it still will help him and anyone with aphasia for that matter if we speak more slowly and if we have patience. If we ask them a question, sometimes what happens is that finding the exact word that they're looking for, they may find a word that's close, but it doesn't impart the exact meaning that they want to say. So they may need a few extra seconds to find that word and say it. And this happens to everyone, even people who don't have aphasia or don't have any what we call dysfunction. All of us experience this. For example, we have a word on the tip of our tongue. And that's the most exact type of example that I can give that people who don't have this can relate to, is when a word is on the tip of your tongue and you know the word and you have this idea in your mind about what it is and you can describe it, but you just can't access the specific word. That's, at least in one area of aphasia, that's exactly what happens in people, is that they can't access that exact word. They know what they're talking about. They have an exact, notion of what they want to say. The sentence is already formed except for that one missing word. And they have to pause and they say, give me a second, I just can't remember the word. Now, we all can relate to having a word at the tip of our tongue. So we give that person a few extra seconds to think about it. And if they can't think about it, they'll say, it'll come to me, just, I'll come back to it. But a person with aphasia, this doesn't happen with one word. This happens often with many words and many sentences. So they can't keep coming back to it. If they keep coming back to it, the conversation would be very disrupted and it wouldn't be helpful. So that's one of the reasons why having patience with someone with this condition is very important, because if they need extra time, and it doesn't mean they need necessarily an extra 5 or 10 seconds, they may actually need 30 seconds. So if you're a family member, you may need to change how you communicate with a person, especially in the beginning, to help them not feel negative emotions. Because one of the aspects to any kind of disability disorder is that in the beginning, especially when you realize that you've lost function, you're not sure whether you'll regain it. Many times people do, but it's not always the case. If you're not sure if you're going to regain it, the emotional state that you're in, the support that you have from others around you, helps with your therapy and your rehabilitation. So if you have people who are expecting you to function as you did before, and they're not patient with you, that will cause stress in the person, that will cause other difficulties in the person, emotional difficulties, which make it more complicated for them to learn. And to give an example where, when he feels relaxed, then this slight stutter that he says he has now, that goes away when he's relaxed. So the emotional state is very important, how we are. And also try alternative words. If the person doesn't understand a specific word that you're getting, try another word that's similar to it. Try to help, and because after all, we're talking about communication, and communication can happen in more than one way. So if you want to communicate with a person, the onus is on you to help and make sure the communication happens with the person that has an aphasia. So this is the example I gave, but the simplest analogy is that the person is basically having to relearn a new language, or for those who can relate more to learning to play a new musical instrument. If you know how to play one instrument and you have to relearn to play a violin, let's say, and you know how to play the cello, then they're different enough, but there are also similarities. So you can rely on the knowledge that you already have of how to play one musical instrument and relay that and extend that into how to play a second musical instrument. So the very similar things happen here, although some of these are subconscious. The person may not be aware that they're doing it, but they're very similar in terms of what's happening in the brain when you're learning a new language or a new skill, like a new instrument. It's very similar in terms of the neuroplasticity that's involved. Also, the efforts. So I'm not going to go too into it, but organisms, intrinsic, extrinsic factors. These are some things that I talked about. Also, this is a non-linear process. Don't expect. So after a person has been stabilized from their initial aphasia, whether stroke related or not, doesn't matter. But after they've stabilized and they are now starting to recover and they're starting to get therapy, the development and improvement in their symptoms and their abilities will not be linear. It will be non-linear. In the beginning, you may see a lot of improvement, and then after a few weeks, you may see it slowing down. And after that, you may see it speeds up again in certain areas, and then it slows down again. So don't expect things to always get better or always get worse. It may go in spurts up and down. Be patient and be supportive of people. The most important things to understand is that the therapies have to, they basically what they're doing is they're accelerating dendritic growth. Dendritic growth, axonal dendritic growth. Axons don't grow as much as dendrites do, but dendritic growth is a primary aspect of neuroplasticity and recovery. It's not the only aspect, but at least in aphasia recovery, it is one of the most important aspects. Because the goal is to rewire the connections and the network, the vast network that we had before this condition. So the reconnections directly translates to relearning, which translates to improvement in skill. And this is the last slide. So emerging trends, so languages, they involve both hemispheres. So these are just some very generic things, not specific to aphasia, but these are effective. They are important in treatments for aphasia. So language is actually involved in both hemispheres. And this is one of the reasons why someone who has had the condition of aphasia, what happens is that the two hemispheres of the brain, the dominant hemisphere in that person has lost function, has lost ability, and the other hemisphere initially starts to take over. And that ability actually can ping pong back and forth between the hemispheres, not rapidly, but over weeks it can move back and forth. And that, depending on how it happens, can be a good thing or a bad thing. It stabilizes eventually. So this is one of those things. There are many things. I'm not going to go into detail, but there are many things that can enhance the neuroplasticity and the recovery after aphasia. But the support system and the environment that people are in are extremely important in this. So let me end here. This is the end of the slide. So.
Well, thank you so much for that, Sanjay. So everyone, this is your opportunity to ask any additional questions that you have regarding this topic. Go ahead and type exclamation point in the chat or raise your hand in Zoom. First up, we have Vanessa, followed by Anne.
Yes, Sanjay, the one video showed in the support group, that gentleman that learned how to draw, especially with his non-dominant hand. Now, doing something like that, might it be possible to learn another skill to communicate, let's say either through music or maybe picking up the cadence where, okay, maybe not verbally. Is that a possibility? And could that like strengthen the recovery or a different option? And where might I look for information on the web about that, good search terms?
Can I ask if like something and kind of rephrase that a little bit as well, Sanjay, if you don't mind? Is this idea of how nonverbal communication therapies and what's their role in aphasia? Because I mean, there are things like drawing that have shown progress and things along those lines, and we talked about Andy with his app. So what are how efficient are they, and what are some of the options as far as nonverbal communication therapies?
Okay, so so the goal after aphasia is to regain and develop as many communicating skills as a person can have. Mm-hmm. And it obviously depends on the time that they can spend on this, how quickly they want to, but typically the most common ones are around vocal therapy. And again, this depends on what's affected. So the assumption here is that their speech and auditory function has been affected, not reading and writing, but if it's reading and writing primarily, or if the person is deaf and their visual interpretation of sign language and their ability to actually create sign language has been affected, then there'd be complementary therapies for that. It wouldn't be sound-based, it would be vision-based. But the modes of recovery are dependent on exactly what happened to that specific person, which areas of the brain were affected. It depends on the extent of damage. It depends on, in general, there other sociological factors. So, for example, if the person, depending on, for example, their profession. So if their profession depends on speech, many of our professions do, then it would be more important for them to regain that. So, and they may be more motivated, and it may be that their insurance provider maybe is willing to spend more money, therefore, for them to regain their ability to earn. So there are many aspects to this that come to play around the therapies that are offered and available, and actually what's chosen and what actually helps a person. The first, most people want to regain verbal function if they had it, but if that's not possible for whatever reason, then there are many types of nonverbal communication. So and by nonverbal, it doesn't mean necessarily non-vocal or non-auditory. Nonverbal, for example, the example I gave and one of the videos demonstrated that is with singing. So singing is a nonverbal, verbal in the sense that non-verbalized. It's not specifically words, although the singing aspect combines verbalization with singing. So it is combining a skill that the person either already has or that they have want to develop, they're able to develop. So that's one example where singing is something that actually helps people, because what we understand with loss in these is that in some cases the person knows what they want to say, they have the sentence in their mind, but they can't convert that sentence into the impulses, into the signals that translate into making the muscles in their mouth move in a coordinated fashion to vocalize speech. Okay? And that happens in the left hemisphere. But singing oftentimes happens in the right hemisphere. It happens in both, but it's a lot more of the control is in the right hemisphere. Therefore, if they already have the sentence in mind and their singing ability, or they have some singing ability, or they want to develop a singing ability, then they use their right hemisphere to start singing. And if the sentence is in their mind, the sentence can flow back and forth between the two hemispheres if there's no damage to the corpus callosum, let's say, right? A lot of this depends on many aspects, but if they can move if the sentence is in both hemispheres, if it's already in the right hemisphere, they can initiate a singing process, which sings the sentence. And that's what, in some cases, people do. And over time, what happens is that actually causes them to sing, and it develops their singing ability, and they have a sing-songy voice. But over time, if they do it in a certain way, it actually recruits other areas in the left hemisphere, which are related to around the periphery of it and near the areas that were damaged. And so they actually start to regain vocalization. And again, what I said about learning a new language, this is what happens when an infant, when a baby starts to speak for the first time a new language, their native language, because their brain is learning to associate audio with thought of word. You know, they have the word mama. This is their first word, let's say. And they learn to, to move their mouth and their lungs and their lips and vocal cords in a certain coordinated way to get that sound mama out of their voice. They have to learn that. And the same thing happens with a person with aphasia. They have to learn to do all of those things to get that sound out, every word. And so as part of that process, in their left hemisphere, which was damaged, they actually may, if they develop enough reconnections, if the neuroplasticity works sufficiently, then they will regain function. And then the right hemisphere, which had taken over the sing-song, can do less of that, and their voice would become more normal over time. So that's an example. So this can be done with many aspects. It doesn't have to be song, but I gave an example with touch, that in some cases, if people have extreme difficulty with either enunciating and hearing, then auditory communication is very difficult with people like that. So you have to resort to physical modes of therapy, at least with communicating with the person. So you start to do things like that. And people like that, what they end up doing is they use, and some people already naturally do, they speak with their hands, right? So people with that, they actually use, so in one of the, I don't remember if it's in one of the videos, I think it is in one of the videos that I posted, where the person actually used gestures as part of their communication. And the doctor complimented the person, you're doing the right thing. He wanted to communicate the concept of the circular, and he actually moved his hand in a circular fashion. And that's an example where the person is using gestures, not simply verbal communication. They're using other. So there are many, many modes that can be employed to help people to communicate. That's in effect what rehabilitation is about.
Thank you for that, Sanjay. Next up, we have Ian.
Okay, question about possible treatment. One hears that deep brain stimulation, implanting devices into parts of the brain in order to enhance neurotransmission is being used in treating depression, possibly other conditions as well. By analogy, then, if some aspects of aphasia are caused by the stroke disrupting neurotransmission, say axonal damage or the like, but some of the cells that would carry such transmission are otherwise undamaged, say the cell body, might be viable in some cases to develop neural implants that would take over and provide the absent stimulation, and hence would accelerate aspects of neurodegeneration recovery vital for recovering functions damaged by aphasia.
Okay, so yeah, so you're asking about implanted devices which augment or supplement the function of the part of the brain that was damaged. So the main thing to understand about aphasia is that there is damage to parts of the brain, and what that means is that there are vast, numbers of cells that have died. And after those cells have died, those cells no longer function. So there's no information flows into those cells or out of those cells. If information is, even if an artificial device sends information into those cells, they won't come back to life. They won't regain. So the cells have permanently died, and the connections between these cells are permanently gone. So let me explain why that's important. Because as a child, when somebody learns language, or anything for that matter, when we learn something, what happens, and we're born with, close to 100 billion neurons. Okay, that's just the neurons, not the support cells. So just with 100 billion neurons, those neurons are starving for information, and they basically catch on to patterns around us. Okay, all kinds of patterns of sounds, of visual patterns, of temperature, of vibration, anything and everything. Our brain absorbs all of the patterns, and it starts to put those patterns into categories and starts to make sense of it. Okay? But that happens because our brain doesn't have any, it has very few already existing connections between those neurons. Those neurons basically exist as sole islands within this vast sea of billions of neurons. And so those interconnections are easy to form because there are very few already. And the first interconnections that form somewhat randomly, and the neurons, the neighboring neurons that they connect with, are somewhat random. But the types of signals that flow and the patterns of those signals that flow are based on what was happening in their environment. For example, the sounds that they were hearing, the language sounds that they were hearing, the phonemes of the language that they were hearing. Based on the pattern in those phonemes, which are characteristic of a specific language like English or German, right? There are specific characteristics. Those patterns have formed into the encodings of their neurons. Therefore, the connections between neurons encode the sounds that they learned to recognize as their native language. Now, after aphasia happens, those patterns and those neurons and those connections are gone. And even if you implant a new device, those patterns won't come back. The only repair mechanism, depending on the extent of aphasia, you may have clusters of regions that have died and other clusters adjacent to it that are living, that are still functioning. But so that would be an example where the extent of aphasia is not as dramatic. So in those cases, you may be able to, because there's less damage and the damage is not pervasive, that you may have a spot, almost spotty type of damage. I mean, it doesn't happen usually, but you can have a condition like that. In those cases, you may be able to augment and support relearning faster. But nonetheless, the only way to do it is that you have to recruit new cells and new connections to those new cells. And what that means is that in a typical adult's brain, and if this happens in adults, this is one of the reasons why it's more complicated, because as an adult, we've already used most of our brain cells in something, in learning something. Okay? It's not that every brain cell is used in detail and everything, but most of our brain cells, are wired to other neurons. And the extent or importance of a specific wiring from a specific neuron may be very high for some neurons and almost doesn't even matter for other neurons. Okay, so the neurons that it matters a lot, if those neurons die, then you have a more severe form of disorder. And if those neurons that die are connected to other neurons, but they're not really important, then it doesn't affect you much. And so similarly, if you have other neurons that survived, if they're connected, the matrix that they're connected with is not very important for critical functions, then those neurons are available to be recaptured and used for retraining. Okay. And the person themselves doesn't know which neuron. It all comes down to how much effort. A lot of it has to do with effort and the personal experience that you have as part of your retraining and the types of therapies that you are involved in. But if you do this in a certain way, you can regain. But whether you have an implanted device, that wouldn't necessarily help, because fundamentally, you have to recapture and retrain new neurons. So if you have some of the devices that are thought of and being worked on don't actually work in this method that you propose, because it's very difficult to do it that way. What they actually do is they try to take the signals, for example, for a certain, if you have aphasia, which makes it difficult to understand auditory sound, what happens in that person is that this device that's implanted in them actually does the processing for them, and it converts the sound into some, let's say, meaning. And then that meaning gets, after it's implanted, they have to relearn and rewire connections from their brain into this areas on this device, sensors or pads on this device. So you still have to have relearning happen. So that's a lot of what happens in that. So it's a very complicated thing, yeah.
One of the interesting things was the example that was given with Bruce Willis. Where it was neurodegenerative aphasia versus this one that is actually able to be recovered from, and it's linked with Alzheimer's. What is the difference between like the one that's degenerative versus one that can be actually treated?
So, I mean, that's not an area that I have delved into, and I understand some of it, but my basic understanding is that the first you have to separate what neurodegenerative diseases in general are, they're in a sense, they're terminal in that they will eventually cause the person to lose critical functions. And
Right.
with enough loss of enough types of functions, they will die from that, because the brain is the one organ that's essential to stay alive, because that one organ controls many other of our organs. So if a person has any aspect of neurodegenerative, any disorder, then that's one thing that's there. So neurodegenerative aphasia, in my understanding, is that they have neurodegenerative elements on top of aphasia. So it could be that the aphasia was there before, and then they developed, let's say, Parkinson's, or let's say, general dementia, whatever, it could be Alzheimer's. So if they had aphasia and they developed a neurodegenerative disorder, then the aphasia would link into that. And one of the characteristics of neurodegenerative disorders is that it expands into more regions of the brain. It starts off in specific areas depending on the type of disorder that they have. But it expands and it becomes more pervasive, but it does affect memory. In almost all cases, it affects memory. So language skills are highly dependent on memory. And that's one of the reasons why neurodegenerative aphasia would be affected by neurodegenerative disorders. That's my understanding, but there may be more behind it.
Sure. And Jason has a question, and then we'll go to.
Yeah, hi, Ian. Sanjay, just want to say thanks so much. I'm actually an urgent care doctor, so hearing about this is a good refresher, but something I haven't really learned too much about in med school. I mean, so this is to me was the equivalent of a continuing medical education lecture that I would normally have to pay for. So I really appreciate it.
Well, he's charging for it, so I didn't. That's coming at the end there, Jason. So.
Did I mention I'm a broke doctor?
Anyway.
But all that aside, Andy mentioned something that was, excuse me, that was interesting. He mentioned the fatigue aspect that he encountered. That was almost, maybe I'm implying a bit too much here, but it was almost like inhibitory. It slowed. It had the effect of maybe you could have made more progress were it not for that fatigue. Do you find that that's common amongst people who are trying to recover from aphasia specifically? And is it more of, is it something that is, I guess, is it a fundamental aspect to what they're recovering from? Like the process of recovery, like is it an essential aspect, I guess, that has to be just kind of go with the flow. If someone's recovering from aphasia and like a stroke and they need to sleep, just like let them sleep? Or is it something that can be, I don't know if circumvented is the right word, meaning if it's not necessarily inherent to the process of recovering, then is it more of just because the patient is undergoing a certain type of stress that they've never been through before, or at least not since they were infants almost? Or is it actually similar to the reason why infants sleep? Is it a similar mechanism at play that where, infants sleep, 10, 12 hours a day or more, because their brain is in the active process of forming connections, similar to an aphasia patient? I think it's probably multiple aspects to my question there, but so feel free to answer any part you want.
Yeah, so very interesting question. Yeah, so I think a lot of so during therapy, one of the main goals is to regrow connections, and that is a very expensive in terms of metabolic activity. It's a very expensive activity. That's one of the reasons why, yes, why infants do need to sleep a lot more. That's another reason why I suspect in aphasia patients and any kind of patient recovering from any kind of neuronal decline or neuronal disease, they would need to rest periodically. It doesn't have to necessarily involve hours of sleep, but in some way they need to maybe change. It also depends on the types of therapies they're undergoing. I think a lot of this fundamentally comes down to the specific situation in the patient, in the person, and also the support group that they have. A major part of any recovery, especially from loss of function, especially loss of function, cognitive function, involves depression. It can lead to many types of difficulties, social difficulties, familial, professional difficulties, and these are all concomitant with the situation they're in and trying to recover and trying to relearn. So all of these things play roles in this. And all that we can do is to support the person and basically give them whatever they need, in terms of resources and time. And maybe they'll, motivation, I think, is a very important part of this. As long as the person has motivation, everything else is much easier to bring to the table. So I think, it's the recovery is so complicated. There's so many parts to it, that, this can't be handled in one talk, but it is really what I would say is look at the patient's goals, because that's fundamental. If they really want to push themselves very hard and they commit to spending hours and hours a day, then give them the resources that helps them do that. Like that's at the end, that's what I think everyone wants. It's a great question.
Thank you, Jason. Ian.
Okay, to piggyback off of the fascinating question raised by the MD about sleep. Well, if there's increased incidence or percentage of sleep among aphasia patients, has anybody tried to determine if there's increased REM content to that sleep? Since REM seems to be associated particularly with learning, also possibly with aspects of physical recovery, for instance.
So I did do a talk on REM a while back, and I mean, again, this is my inclination would be, and again, I can't answer definitively, but I don't think there would be any increased REM activity from this, simply because the sleep that we're talking about, and again, whether they go into REM state or not, it also depends on the duration of their sleep, depending on how tired they become. REM sleep happens at nighttime when we have, basically they run around 90-minute cycles, around 70-minute cycles on average, but 70 to 90 minutes per person, and it's multiple times in the night. But if it's daytime, they probably aren't sleeping long enough for them to actually sink down into the level of REM sleep. And if they do, get to REM sleep itself, at least the more recent understanding of REM sleep is much more complicated, that a person within a single REM cycle may actually pop in and out within the short duration. So some people have very short periods of REM sleep, other people have slightly longer periods. But in general, I forget the exact, but I think the duration is around 30 minutes most of the time. But again, that's not a strong number to rely on. So I don't think that aphasia necessarily would cause them to be in REM sleep for any longer, because REM, one of the things that we believe about REM is that it's helping to rebuild and recover a lot of from the activity of the day, from the activity of the previous 24 hours. And in terms of aphasia, that would have happened. The person would have gone through a lot of activity, but that activity would be focused in a specific area. And REM sleep is more broad and more general around, it's not focused only on listening. I mean, what may happen, one thing to posit, one thing to speculate on is whether the nature of their REM dreams are related to language or not. That may be. I can maybe say that might be more plausible. That if they're having a midday long period of rest in which they go to REM sleep, that REM sleep may actually have more to do with language than not. But a very interesting question, Ian.
Yes, thank you, Ian, and thank you, Sanjay. This has been fantastic. This has been one of the more interesting meetups on in your neuroscience series. It really is, and I very much appreciate it. So I'm just going to do a quick announcement of some upcoming events. And upcoming events are, we have the Gospel of John tomorrow. We'll be covering chapter 13, God Washes Man's Feet. And then on Friday evening, we have our new series, Designing Your Life, where we'll go through a series of values exercise, often used in cognitive behavioral therapy, as well as there'll be a presentation by Jeng on a that focuses on the why and the purpose people take their actions, and examining why do people do what they do. Then on this Saturday, in conjunction with the Asian Philosophies Group, we'll be continuing our series on a Chinese cosmologist in the Sung Dynasty. That is at 7 p.m. on Saturday. Then on Sunday, a very, very interesting new series is Trivium University. It's actually being launched here, and they'll be covering the paradigm shift from electric to digital, and how has the new digital paradigm changed our senses, which should be a really, really interesting discussion. And I hope to at least make half of that. And then we have Goethe's Faust at 5 p.m. And followed up by Learn to Speak and Write in Classic Style Using Clear and Simple as the Truth. That's just a book that Shrikant has been studying, and that is by Mark Turner, I believe, is the author of that book. So if you want to get that book and join that series, that is also available to you. So there's quite a bit actually coming up in the next few days. I didn't realize how many of these events that there actually were. So again, thank you, Sanjay, for your contributions this evening. It really was quite wonderful. And I will see everyone again soon. Take care.